And I'm going to introduce our next speaker. My computer seriously, it's hilarious. Today is the day. So next up, we have a presentation titled Long COVID Care in a Virtual-Based Community Setting, My Experiences Utilizing a Learning Health System Approach for Community Engagement. And my apologies, our presenter is Danielle Wittal, and she's actually a research coordinator with the IH Research Department, and it is just an honor to introduce her today. And Danny, take it away.
Thanks, Kim. Just making sure you can see the presentation okay. That's good? Okay. All right, so thank you so much for attending our IH Research Week. My name is Danielle or Danny Wittal, and my presentation is titled Long COVID Care in a Virtual-Based Community Setting. So my experience is utilizing a learning health systems approach for community engagement. So I just want to say that I'm a daughter, wife, mother, and aunt of Scottish, Irish, and English descent, and I recognize and acknowledge that I live, work, and play on the Tecumseh territory situated within the unceded ancestral lands of the Secwepemc Nation. So what I'm going to be talking about today, I'm going to give you a little bit of background. I'm going to talk about a learning health systems, our interior health model of community care, give you some results, some challenges, and some lessons learned. Okay, so this project builds upon the post-COVID-19 interdisciplinary clinical care network, so with the acronym of PCI-CCN in British Columbia. So the PCI-CCN was implemented in 2020 to provide care and support to patients experiencing persistent symptoms after recovering from a COVID-19 infection. So given IH's large catchment area, a virtual model was considered the best option for providing care closer to home. And part of our role in IH was to utilize ongoing research to guide and adjust the program as needed. So what is long COVID? Long COVID is defined as symptoms experienced following an infection with SARS-CoV-2 that is unexplained by an alternative diagnosis, and that persists beyond 12 weeks. So there can be many symptoms associated with long COVID. It can be physical, cognitive, social, emotional, requiring psychological, social, and medical care support and education. So the impacts from long COVID can be significant, and symptoms can involve multiple body symptoms. So why long COVID? It's important because it's a new emerging disease that kind of confused the medical system. So we have patients presenting with incredibly complex care needs, and managing that care typically requires the involvement of multiple healthcare professionals. And patients often felt alone and isolated, separated from normal life. So it was important to me to create a program that prioritized minimizing these feelings of isolation and loneliness while fostering a sense of inclusion and a sense of belonging. So we used a learning health systems framework, which enables real-time evidence gathering, knowledge generation, and decision-making to drive continuous improvement, collaboration, and innovation within our healthcare system. So we wanted to apply research in real time using patient feedback to make immediate, impactful changes. Unlike typical healthcare improvements, which usually take a lot of time, the learning health systems framework allows for quick adjustments, enhancing patient outcomes and resource utilization. So broadly, we wanted to create a quick and effective improvements for patients. So this dynamic patient-involved approach ensures that care remains relevant and efficient by continuously evolving based on actual patient experiences. So it is this ability of the learning health systems to adapt quickly, which facilitates quicker action. So why me? So I joined the research project when the opportunity came up through connections and networking I had made during my time as a radiation therapist. So at that time, I was commuting to work in a different city, so this felt like a really big change. Initially, I wasn't sure I was the right person for the job, as I'd never done anything like this before, and the whole experience was really daunting. Coming from a comfortable workplace where I had done the same job for over a decade, this felt like a huge leap. Luckily, I'm generally always up for a challenge and eager to grow and learn. But growth and learn and change doesn't happen without discomfort, right? I came into this with minimal research experience, but leaned on my ability to my patient care background and my ability to connect and relate to people. It took about 6 weeks for me to realize that I actually might be the right fit for this. I had my aha moment, if you will. So we were mapping out some next steps, doing some brainstorming sessions. And this was the first time that I was able to recognize that my past experiences working with BC Cancer might actually be an asset for this particular project and population of patients. And so coming from that background in oncology and a specific interest in approaching care from a whole person perspective, I was finally able to see how the pieces of my past education and experience would tie in nicely. Okay, so my main goal was to provide a safe and supportive space for patients to connect, to receive care and support, and to provide like a learning atmosphere and environment. The goals of our virtual program were to provide that patient-centered care through a virtual platform, ensuring patients were thought of from a whole person approach. We opted for the virtual option because of the large catchment area in interior health, and it allowed us to reach and provide care to a wider group of patients. At first, I kind of assumed connecting with people virtually would be challenging, but I was pleasantly surprised to find out that it wasn't. Drawing from my past experiences, I recognize that effective patient care cannot be provided by a single individual and that a multidisciplinary team is essential. In radiation therapy, care is delivered by a dedicated team of professionals, which helped shape my advocacy for a similar approach to address that full spectrum of patient needs in long COVID. Understanding that symptom burden of long COVID is similar to other chronic conditions shows the importance of a team to address the physical, mental, and social aspects of care. This whole person approach ensures that comprehensive support, fostering patient engagement, empowerment, all through a learning health systems framework that promotes that continuous improvement. The entire concept of building a program grounded in both research and patient experience was completely new for me. Dr. Barbara Buckley, who is an experienced researcher, was instrumental in providing her insight and expertise while supporting the program development. A learning health systems framework allowed us to assess patients in real time and make the necessary adjustments. We continually asked ourselves, are we providing what is needed? If yes, great. If not, we worked together to identify what needed to change. This helped to gain a deeper understanding of the program's impact and highlighted areas for improvement, ensuring that the program is continuously meeting the needs of everyone involved. So what did we do? So in our interior health model of community care, we developed a virtual post-COVID community of support using an interdisciplinary team-based approach that integrated research into all core clinic activities. We utilized a multidisciplinary care team to address that full spectrum of care needs. So by conducting surveys after each patient encounter, whether it was an RN visit or an allied health class, we applied the learning health systems framework by continuously gathering feedback in real time and using it to improve care practices on an ongoing basis. We connected with other healthcare providers running chronic disease clinics within interior health to learn from their experiences and gather practical insights for our program. This collaboration played a crucial role in shaping our approach, and in hindsight, led to us utilizing this learning health systems framework unintentionally. Okay. So as the program coordinator, I have a background in oncology and a strong interest in taking a whole approach to health. It was important for me to ensure that we viewed individuals in our program as more than just their disease, and to design a program that addressed their overall well-being. This approach required the inclusion of a diverse range of healthcare providers and allied health professionals to support every aspect of patient care. Our principal investigator is Dr. Barbara Buckley. She successfully coordinated 3 focus groups and conducted 24 one-on-one interviews. Her expertise in research played a crucial role in the success of our learning health systems framework, allowing us to gather essential data and achieve impactful results. Her contributions were instrumental in shaping the program and ensuring that we stayed aligned with our goals. We involved our patient partner in the program development process from the very beginning. Our patient partner was a paramedic in her early 30s, very active and fit before contracting long COVID in the early stages of the pandemic. By the time we met, she had been off work for nearly 2 years, and long COVID had dramatically altered her life. We had extensive discussions about the key issues that need to be addressed for people with long COVID from someone with lived experience. Our shared goal was to ensure that patients felt supported, connected, heard, and valued. I felt her contributions were instrumental in shaping the direction and success of our program. So we had 2 registered nurses involved in our program with backgrounds in public health and ICU nursing. So nursing plays a vital role as nurses provide that in-depth assessment and case management aspect that can help streamline a patient's care trajectory. So this support can ensure timely interventions, coordinate services, and ultimately enhance the overall patient experience. Our physiotherapist and social worker were both dedicated members working in our community. We collaborated closely to ensure the program followed best practices and embraced a whole approach. Including physiotherapy and social work was essential as many patients with long COVID experienced a range of physical and emotional challenges that required that comprehensive support piece. Together with everyone's contributions, we developed and provided a safe and supportive program for patients that considers the whole person and addressing their overall well-being. We learned from one another throughout the process, which truly reflects the essence of a learning health systems approach. This collaborative learning and adaptability allowed us to continually improve and provide care that was responsive to the diverse needs of our patients. Okay, so we offered a variety of allied health classes. Both our physiotherapists and social workers collaborated with allied health care workers in the Lower Mainland. They attended their sessions and tailored their own offerings to meet the specific needs of our patient population and interior health. Our physiotherapist provided post-exertional malaise, breathlessness, and symptom titrated. And our social worker provided mental health, grief and loss, and sleep sessions. By having group sessions, we were able to address the full spectrum of patient needs and provide comprehensive support. The diverse topics covered in these sessions allowed patients to engage with multiple aspects of their recovery simultaneously. For instance, the physiotherapy sessions help patients improve their physical fitness and manage breathlessness, which are critical for enhancing overall mobility and quality of life. At the same time, the social workers sessions provided a safe space for patients to explore their emotional challenges, process grief and loss, and develop strategies for better sleep. This integrated approach not only fosters a sense of community among participants, but also encourages peer support, which can be incredibly beneficial for mental health. By addressing both physical and emotional needs in a collaborative setting, we can ensure that our patients receive care that promotes their overall well-being and facilitates a more effective recovery process. As the program coordinator from the beginning, I believe strongly that nutrition should be included. Knowing that nutrition is an essential component of health and healing, I advocated for the inclusion of a nutrition class. In conversations with other program coordinators across the province and our patient partner, it was clear that nutrition was not only important, but an existing gap. Well, this example kind of was not initially intentional. It serves as a reflection of how the learning health systems framework was applied at every stage of our program. We engaged with the registered dietitian to create a dietary class specifically for our long COVID patients, which was not run only in the interior, but also offered provincially as well. Patients were able to sign up for classes at their leisure, only attending classes which suited their needs. This flexible approach empowered patients to take control of their recovery journey, allowing them to focus on the areas most relevant to their individual circumstances. Okay, so after the first few weeks of our program, feedback began to come in. Patients were enjoying the existing programming, however, felt that they needed and wanted a bit more support. This information was gathered through surveys that each patient completed after every encounter with our program, such as following a visit with a registered nurse, attending an allied health class, or interviews conducted by our researcher. Through discussions with our team, we decided to add initiatives such as coffee club, meditation, and journaling club. So the coffee club was established based on patient requests for greater community engagement. While I had limited experience facilitating these types of groups, I was eager to learn. Through these sessions, we created a safe and supportive environment where individuals could connect without fear of judgment or gaslighting, fostering that sense of support and community. Since living with long COVID often led to feelings of isolation, anxiety, and depression, this coffee club aimed to help alleviate some of those emotions for our patients. After we closed our program, patients used, prior to closing our program, patients used these sessions to exchange personal information and further build their own support community past our programming, creating a network that hadn't existed before. We incorporated meditation due to patient requests for relaxation techniques and breathing support. This addition complemented the breathlessness class led by our physiotherapist. Luckily, I myself have a training in pranayama meditation, so that easily allowed me to fulfill this request. Journal Club was incorporated as patients were wanting more information. They wanted to learn about new medications and trials. They wanted and they needed more. Many patients in this group felt isolated and were desperate to improve their condition, so they wanted any information that might help them in their recovery, in their journey to recovery. In my experience, the Learning Health Systems framework is highly effective for implementing immediate changes. It focuses on real-time feedback and continuous learning, allowing us to respond quickly to patient needs and outcomes. By adapting our practices based on the latest insights, we can ensure that care stays relevant and improves patient outcomes. And this approach creates a dynamic environment where changes can be made quickly, leading to better care. Okay, so this slide is showing the response from our allied health survey sessions. So we received a total of 42 responses with a good variety of feedback across all offerings. Patients were emailed an anonymous red cap survey link through which data was collected. The sessions on symptom titrated, meditation, breathlessness, and coffee club gathered the majority of responses, which aligns with the high attendance observed in those classes. This consistency suggests that these topics resonated well with participants, reflecting their interests and needs within the program. Our goals for the surveys were to assess whether our program offerings were beneficial to patients, and if not, to identify how we could make changes to better support and assist patients. Of the 42 responses, a majority felt strongly that sessions met their expectations. I felt we had accomplished what we had set out to do, and patients were very satisfied with the program we had provided for them. Okay. So this slide represents the results of the patient experience following their visit with the registered nurse. Capturing this information was crucial for us as we aimed to determine whether patients felt heard and validated during their interactions. We wanted to assess our effectiveness in evaluating patients and ensuring they were appropriately streamlined into the right care pathway. As you can see, a majority of patients strongly agreed the healthcare team treated them with respect and kindness. They felt validated and heard when discussing symptoms, and the healthcare team asked about their goals in recovery. Using REDCap as a survey tool wasn't too familiar to me, but I was pleasantly surprised at how easy it was. The survey needed to be short and sweet as we wanted to gather as much information from the patient, but we also were aware of the cognitive challenges that came with long COVID. We wanted patients to fill out the surveys, so we ensured that they were short and sweet. The survey results show how well the Learning Health System framework works. We gathered evidence and data in real time. We generated new knowledge. We made change. Our goal was to ensure we were improving patient experience, and I felt strongly that we achieved that. Okay. So many patients expressed gratitude, sharing feelings of being abandoned by the healthcare system and relief upon finding our program. It wasn't uncommon to hear people say, "I feel like everyone looks at me like I'm crazy and I'm making up my symptoms." Our coffee club sessions attracted regular attendees, creating a space for participants to connect and build relationships, which enhance their overall emotional well-being. The surveys showed that patients felt informed, supported, and validated, often describing our team as a lifeline. We were always in a learning mindset, seeking to understand what we were doing well and where we could improve. This feedback confirmed our goal of supporting a safe and supportive space for patients to connect, to receive care and support, and to learn. Some noted the absence of a physician in our program, which I completely understood. At the beginning, I felt strongly that a physician should be included to provide that whole care approach. But over time, what we learned was that most people required the rehabilitation approach first, and then physician management if the rehabilitation support was not effective or not enough. That model of care required collaboration among various professionals to meet each patient's diverse needs. The teamwork among our allied health professionals has been remarkable and has not only improved patient outcomes, but has also demonstrated the power of a collective approach to care. Utilizing the Learning Health Systems framework, we were able to introduce initiatives such as coffee club, meditation sessions, and journal club. And these initiatives aligned with the patient needs and improve the support we provided. Okay, so there was so much going on behind the scenes to create a program that was patient-centered and that delivered care through a virtual platform and one that ran smoothly. It was very important to me to ensure the program was well organized and to be able to provide timely, personalized support while fostering a seamless experience to patients with no gaps or no issues. What seemed straightforward turned out to be quite complex. At times it felt daunting and frustrating, highlighting why changes in healthcare can take so long. The planning, coordination, and adjustments required were more challenging than I initially expected. We spent months discussing the IMIT, so information management and information technology aspects of implementing the virtual project and ensuring that we were compliant with patient privacy. This process was really slow, especially during the pandemic. It often felt like a 2 steps forward approach and a 1 steps back, making progress seem almost impossible at times. The program implementation came at a time when there was healthcare shortages across the board. So as mentioned, we had a physiotherapist, a social worker, and nursing staff, but struggled to find an occupational therapist, which was a gap in our program. Luckily, our physiotherapist adapted her practices to help fill it. Coordinating consistent messaging across BC was a significant challenge due to the province's diverse urban and rural needs. So balancing standardized provincial guidelines with the unique demands of our region required careful planning, time, and patience to ensure our program was aligned with the PCI-CCN, but also responsive to our patient needs in the interior. While the program operated under the umbrella of the PCI-CCN, we had the unique opportunity to conduct research, which allowed us to adapt and evolve in response to the needs of our patient population using the Learning Health Systems framework. Okay. So having not been involved in anything like this before, this task was significant and presented many challenges. Coming from a background in BC Cancer was a challenge, and the IH was a new territory for me to navigate. Navigating the complexities of developing and implementing a program of this scale required a steep learning curve, as well as adaptability in overcoming obstacles along the way. Learning ways that IH operates, understanding the health system as a whole was a new learning for me. There was all the emotions, excitement, fear, frustration, I'm sure a little bit of anger as well at how things operate. Luckily, I had great mentors and support to help me navigate this new terrain. Despite the challenges, it was an exciting experience. It was something new, bringing together members from various health backgrounds to create a program that ultimately worked so well. Looking back on it now, it's impressive to see how far we've come and how collaboration made such a meaningful impact. Through all the challenges that were thrown our way, we persevered. Thanks to a dedicated team that worked collaboratively, we were able to create and implement a safe, supportive program. This experience fostered significant personal learning and growth, and a lot of professional learning and growth as well. What would I do differently? Well, I am pleasantly surprised with what we were able to do. There's a couple of things that we would do differently. I would try to build on an existing service that's already in place by making long COVID a branch of that service. So this could run parallel to another chronic disease clinic, allowing us to adapt the existing resources and support services that are already available. This approach could help minimize delays in getting started and streamline the integration of long COVID care into the current framework. I would advocate for more time, the time to continue nurturing and fostering the relationships we'd had built. This additional time would allow us to further support individuals in their journey, helping them transition from merely coping with long COVID to truly thriving. Okay, so again, my main goal was to provide a safe and supportive space for patients to connect, to receive care and support, and to learn. And we did this. And I thought we did it well. We met our goals, and as a result of that was a really positive patient experience. Some of my key takeaways from that, though, is collaboration is key. This is not a new concept to me, though. However, this experience further embedded that engaging with multidisciplinary teams and stakeholders is essential for success, and that these diverse perspectives really helped us to shape a well-rounded program. The importance of being flexible and adaptable for ourselves as healthcare providers. We need to be flexible and adapt our approach to patients' needs. It's not about what we need, it's about what they need. The value of a continuous improvement. We were able to do this by implementing that learning health system framework to learn in real time and make changes based on patient experiences and outcomes in this ongoing learning cycle of continuous improvement. And the importance of patient feedback. I can't undervalue the importance of this. By actively seeking and incorporating patient feedback through our surveys, we were able to adapt our offerings based on the emerging needs of patients, adapting a program which supports patients from every angle. That was from kind of exactly right around what they needed and they wanted. Okay, so this entire process truly embodies that learning health systems framework to me. The ability to take an unknown situation, learn from challenges, colleagues and mentors, and implement a framework that reflects real life experiences has been both an incredible journey and an invaluable opportunity. The dynamic nature of adapting and evolving in real time while continuously learning and improving is at the heart of the learning health systems model. And this experience has highlighted the power of this approach to me. Okay. Thank you for listening, and I welcome any questions.
Thanks so much, Danny, for that wonderfully insightful and personally reflective presentation. I really appreciated that. And I welcome anybody, if you have a question, please feel free to put it into the chat box, and I'm happy to read them out for Danny as we move along. In the meantime, until we receive a question in the chat box, I can start us off. We got 5 minutes, which is great. So you talked about the multidisciplinary team, and you talked about a person with lived experience, like really co-leading the path alongside. And I wondered if you encountered, like, and from your point of view, if you encountered any hiccups with collating that multidisciplinary team, because there's so many different facets within the healthcare system that all came together to support that care. So I wondered if that was how you felt that process went, if that was an easy process, if there was a little bit of hurdles to overcome with it. Yeah, just any insight you can have on that would be great.
Yeah, luckily, like I myself knew the physiotherapist. I had worked with her in my cancer world, so we kind of had a previous dynamic and relationship that was really good. Dr. Buckley knew our social worker, so I really felt we all worked really well together, and we all really just had the same goals. We wanted to create a great program that was supportive for patients. Some challenges, though, it was some people were doing this in addition to an almost full-time working job. So that was definitely a hurdle to try to ensure we had enough time to present and to have the classes that patients needed. I think an advantage to that was some classes were in the evening. And so some of our social worker classes were in the evening, which patients appreciated because some patients were still working while trying to get better and heal.
Thank you. I'll give a pause just in case. I guess I also have to ask, what's next? Because I feel like there's going to be something next when it comes to this. And if there's anything you can share, if not, that's okay too. If share this time, but I know that post-COVID, complications aren't going anywhere. They're still very prevalent in society, and with community members that we want to support, and we want to continue elevating voice for and with. So I wondered if there was anything planned for what's next.
There still is an existing provincial program. So patients, there is still support kind of provincially now. We conducted a phase 2, which was physician engagement, trying to understand physician perspectives. And so with that, we are now hoping to run some physician engagement, lunch and learn, so we can get a little bit more information out there. Because I do think there's still some physicians out there who may need a little bit more information around long COVID and how to help their patients. just as I mentioned, due to the complex needs of COVID, and there's not an actual diagnostic test saying, yes, you have COVID.
Mhm.
So I can imagine that's both challenging from a physician perspective and the patient as well.
For sure. Is there any final words you want to leave us with? I know that like my biggest takeaway was the power of relationships and having those built pre and then during and then post, and the importance of needing time. Is there anything else that you would want to share before we move on for the day?
Yeah, I think even just the whole learning health systems framework or as a whole, I think a lot of us do it all the time without realizing we do it. And I had a few of those moments that I mentioned after that. We were doing it from the get-go I wasn't even realizing we were doing it. So I think that's just embedded in how I kind of operate. And so in that regard, it was, I think, an advantage to the programming. Yeah, I just think also just taking a minute to learn from everybody, right? We're always always on the learning journey, I think is really important.
Well, thank you so much. Thank you for sharing reflections and insight, and for being part of this wonderful work that's really reshaping the the landscape in such a good way. It's very appreciated.
Thanks for having me.
And
You're muted again.
You're mute. Yeah, I'm muted.
I'm serious. My computer is just done. So I'm not sure what I always was heard. So I'm going to start from the beginning. It's an extreme pleasure again to introduce the next speaker, Dr. Kathleen Scullion, who works with our Interior Health Research Department as well as a practice lead. And the presentation is titled Doing Research with Interior Health. And I'm so grateful that she's agreed to add a spotlight. She's agreed to present with us, and take it away, Kathleen.
Thanks, Kim, for the introduction. Just going to share my screen. Can you guys see my screen?
Yes.
Perfect. It's all good?
Yes.
Thanks, Lindsay. All right, so this presentation is about doing research with interior health. This will cover whether you are an employee or medical staff with interior health, or if you're external to interior health. And Kim, just so you know, if you see any questions pop up along the way, please don't hesitate to interrupt, because the way that the slides are set up, that there'll be, I think, questions pertaining to specific slides. So I'd just like to start with an acknowledgement that I am situated on the traditional, ancestral, and unceded territory of the Silks Nation, also known as Kelowna. So first, what are the requirements for research with IH? You need 4 things, which are actually 3 things that culminate in the final institutional certificate of approval, and that's why it's bolded. But you need ethical approval, operational approval, and any executed agreements. And so you need those 3 things to be issued the institutional certificate of approval. And that is the piece of paper that truly lets you conduct research with IH. And so this presentation will go through each of those 3 steps. But IH isn't a part of the study. I'm not doing research with IH. However, the study only requires lab services or poster placement from IH. And that means to us, you're doing research with IH. As soon as you're requesting services from IH, you are doing research with IH, as long as it's for, obviously, a research study. So what do we consider research within IH? If your study team member is cross-appointed or an IH employee or medical staff member, if you're requesting data from IH, whether this is aggregate data or row level data, distribution of recruitment materials. As I said, this could be poster placement, or it could be access to our listservs, using IH services, whether that be lab, diagnostic imaging, cardiac services, any of those things that are used for a study. as well as generally using space within our facilities. So if you need to book a meeting room within one of our facilities for, say, a focus group that you're running, then that is considered doing research with IH. So first up is your research ethics application. If you are with the Research Ethics BC network, we would ask that you harmonize your ethics application with IH. To do this, you just log into RISE, and in the section 4.2b and 4.2d, you would write interior health and then the specific site that you would like to work with if you know it. If not, leave it as interior health, but then also place which service you are looking to partner with us for. This will cause a page 11 to open up, which asks 3 simple questions. I believe they're yes/no questions, and we ask that you complete these questions on the page. This will allow your REBA to know that you need to be harmonized with the IHREB. If your institution is not a part of the Research Ethics BC network or is outside of BC, you can contact Research Ethics at interiorhealth.ca for the IHREB application form. Please note, though, that if you are, say, from Alberta, and we'll say Athabasca University, because that's the one that came first to mind, and you've already got like a REB certificate from Athabasca University, you can submit your entire applications package that you sent to Athabasca, and you can send that to our REB, and the chair will review your completed application to determine if it meets all of the requirements of IH's research application. And if it does, then she will accept the approval from your home institution. If not, she'll likely ask you to apply to our own REB so that there isn't that duplication of work, as long as your home institution's REB application meets all of the requirements of IH's REB application. So our research ethics board is run entirely by volunteers. They do this work off the side of their desk. They meet the first Thursday of each month, but take August off. If there is a stat holiday that lands during the school year or like a school week that's off, that will usually move that to the following week just to adjust for everybody's schedule. If you're going for a full board review, which is an above minimal risk study, your deadline to get your application in for that meeting would be noon the Monday 3 weeks prior to the meeting. There are no deadlines for submitting minimal risk studies, and this is because as soon as the IHREB leader receives the application and sees that it is minimal risk, she then sends it out for delegated review to 1 or 2 IHREB members. And that usually takes around 2 to 3 weeks for a member to review, because again, remember that these are volunteers doing it off the side of their desk. Operational approval is another thing that is required. It is separate from the ethics application. So yes, you do have to do 2 separate applications. You can begin this application at any time. You can start it before your ethics or after. However, it typically will be easier to complete if you have done your ethics application already. It provides details about the study and the resource request that you have to IH, and it can require up to 3 forms to be filled out, and you must submit your REB certificate to the operational approval team. And we'll get more into about who that team is in a few slides. But first, the operational approval process itself. First, we require you to submit the study intake form. Upon completion of that, you will receive an email link for the operational approval form. Depending on what you put in your operational approval form, if you're requesting data, you will then receive a data request form. Once all of that is complete, the operational approval team comes in and goes and sends off the application to the administrator for approval. Once the administrator provides approval, we then check, the operational approval team then checks all other approvals are in place prior to releasing the institutional certificate of approval. So first, the study intake form. If you click this link, it would take you to it. I think I've put it in the resources at the end of this presentation. So you can take a look there. But basically, it gathers demographic data about the research study. So who is the principal investigator, the primary contact, and how do we get a hold of them? And just to note that the PI on this form must match the PI on the ethics application. If it does not, we'll be reaching out to you and requesting clarification on why they are different. Once the study intake form is submitted, you'll then receive the notification to complete the operational approval form. Sometimes, since we use the platform REDCap to do all of this, sometimes it will be sent to your junk mailbox. So if you don't receive this email within, I'd say 30 minutes of completing your intake form, please check your junk mailbox. And if it's not there, then reach out to the operational approval team at research@interiorhealth.ca, which again will appear on the resource slide at the end of this presentation. So this is the notification example. So you'll see that it comes from research@Interior Health, and then in the brackets, REDCap@PopData, because that's the platform that we use. Action requested, operational approval form. This link is specific to your study application. And if for whatever reason you end up misplacing this link or you need to re-access it, again, just email us and we can give you a link and access code so that you can go in and make any changes as required. So I just wanted to let you guys see what to expect to arrive in your inbox after completing the study intake form, and you would receive a similar email upon completion of the operational approval form if you selected that you were requesting data from us as well. So within the operational approval form, we ask you more details about the study, such as like, what is the purpose? What is your intended audience? How are you going to let IH know about the results of your study? And we encourage you to use your study protocol and or ethics application to aid in answering these questions. You can actually just copy and paste into the correct areas. Within the operational request section, this is where we ask you to describe what you would like IH to do for you. Specific details are better because then the operational approval team is able to understand your request and without having to reach out to seek clarification. Because the way that the operational approval team interprets your request will determine who we send out your application to as an administrator. And if we can get that person right on the first try, that always makes things go more smoothly and faster in the end. And as I just said, we'll reach out to the primary contact for clarification if necessary. If you're requesting access to data, you will then receive an email notification to complete the data request form. For the data request form, if all your study is requesting is the data, we would still ask you to go through the study intake and operational approval form, because this just allows us to keep track of the various requests for IH resources. And the form itself just asks you to provide specific information about your data request. So who's your cohort, what type of data are you looking for, whether it be aggregate, de-identified, or identifiable information, how you plan on collecting it, such as data extract versus access to our Meditex system, or other type of systems that we have, and where you're keeping the data, as well as any plans for transferring of the data. And we also collect information on study risk and privacy mitigation, such as, are you collecting patient consent for this data or not? And again, like, what physical and technical security measures do you have in place for protection of the data? And again, you can use your study protocol or ethics application to aid in answering all of these questions. So with those 3 forms, your OA application is complete. Yay! But now what? Well, if we go back to our process, we now look at the administrator approval form. However, we need to get the OA team involved for that first. So the OA team reviews the application to determine human and or physical resources that are being requested. And we may reach out to the study team to ask for clarification. We then identify the IH administrator with responsibility for the impacted portfolios. We do this by using our staff directory. And if we have have any lab champions that we know of, we'll reach out to them within the specific portfolio first, and then they will usually redirect to the appropriate person within their team. We also work with IH privacy to determine which, if any, agreements are required based on the data that's been requested. If there are agreements that are required, we will reach out to the study team to inform them, and we will facilitate signing of the signatories, by the signatories, with those agreements in conjunction with IH privacy. So the IH administrator approval process, once we identify them, we send out an email to the administrator informing them that there is a study that requires their approval. And we always CC the primary contact and or the PI of the study on this email. So they now have access to the administrator who is providing approval. The OA application is then sent to the administrator via REDCap. They receive a similar email as what you saw before for review and approval. So we send that out as soon as it's a completed application and we've determined who the administrators are. And then we send up a follow reminder email every 2 weeks to the administrator if they have not actioned the approval. However, we want to remind you that it is ultimately the responsibility of the team, of the study team, to ensure receipt of approval. We also encourage the study team to introduce themselves and the study to the administrators. And that can be done once we send out the administrator heads up email that you'll be receiving this application from our REDCap. Because I gotta tell you, we receive hundreds of studies every year, and it's a lot to keep on top of the every 2 weeks. But if a study team takes it into their hands, it can make the process move a little bit faster, because then the administrator can ask the questions that they might have about your study directly to the study team instead of coming to us. And then we do the broken telephone game. We then have to reach out to the study administrator to be like, okay, these are your questions. We'll now reach out to the study team. Hey, study team, this is the administrator's questions. And you respond, and then we have to relay that back to the administrator. So if we can cut out the middleman, that would probably make things go a little bit faster and in your favor. The administrator approval form itself shows everything that you have filled out from the study intake form, the operational approval form, and the data request form. It allows them to select if they are the appropriate person to provide approval or not, and they're able to redirect us. They can say, well, actually, I think it's Joe Smith that should be looking at this instead of me. It also allows them to provide conditions and comments of approval. A common one that we see is from health records that there is a cost associated with doing chart reviews if it is for research instead of quality improvement. And also, we'd like you to know that the approval is treated the same as consent. It's ongoing and may be revisited at any time. What does this mean? It means that, say, if you're requesting lab services and they agree, they say, yep, we can support this study right now because you're requesting blood draws and we have enough people on the floor to do this. Great. And then 6 months go by and the study's still ongoing and things change because people have gone on mat leave or they've gone to a different job. They can come back and say, you know what, we can't support this study anymore because we don't have the human resources available for it. And if that's the case, we would then get in contact with the study team and let them know and facilitate a discussion between the study team and the approver who wants to revoke their approval. And in this case, it usually what ends up happening is we come to a compromise. It's not like the end of the study. It would be like, we just have to press pause for now and we'll come back a few months later, or we'll revisit in a couple of weeks, or can we just provide you with a data set instead of running the lab samples for you? So your OA application is approved. Yay! But now what? So going back to our process, the operational approval team now has to check all other approvals are in place. So what are these? Well, have we received an REB certificate? Yes or no? A lot of times we do not receive the REB certificate from the study team, but from our REB leader. And She has made it clear that this should fall on the study team. We do reach out to study team and ask every so often if they have received the certificate, and if so, could they please send it to us? Have all required agreements as applicable been executed? What are these some of these agreements that we use? It could be a clinical trial agreement, confidentiality undertaking, letter of agreement. Those two are related to data, most typically identifiable data that we are providing to you. Privacy compliance agreement is if you would like access to IH servers, and that goes hand in hand with the external user access agreement. And all of these agreements need to be executed before you can receive your ICFA. So we checked and all the other approvals are in place, and that means that we can now issue the institutional certificate of approval. So what is this piece of paper? It's what allows you to conduct research within IH. It's created by the OA team. Once it's been confirmed, all approvals are in place. Our corporate director of research provides the final sign-off on this, and this process takes about a day, sometimes two. And then once all of that has happened, you will receive an email with the ICFA along with any conditions provided by the administrators of their approval. And now you may condense your research. So yay, congrats! You may begin your research. And then you go, uh-oh, but now I need to change the ask from IH. What do I do? It's really easy. You just put forward an amendment in the same way that you would your ethics application. So if you have changed your ask to IH, we ask that you check your operational approval form to ensure it still contains a complete and accurate description of the study. And if it doesn't, just reach out to the OA team requesting your link and access code. And from that, you can click on that and make any changes. We just ask that you type in bold, like amendment, and then the date so that we know what the changes are to your application. And of course, as always, like make sure that you in tandem update your rep, submit a PAA as well. And then once we receive your change, we will review it. And then we have to decide, do we need a new administrator? So you were only asking for lab services before, but now you would like an MRI to be used. So then we would have to add the diagnostic imaging administrator to your application. And so then that might take a time for that to happen. We would just ask that you do not action any new changes in your protocol until you receive that approval from our administrator. And once that approval is received, the OA team will notify you saying your amendment has been approved, but we do not reissue the ICFA. It will just be a confirmation email saying this person has approved your changes. So here's the list of resources. And that's the end of the talk.
Thanks so much, Kathleen. I'm going to try and figure out my stuff here. There we go. I've added myself as a spotlight as well. Perfect. So feel free, everyone, to please enter any questions you might have into the chat, and I'd be happy to relay them to Kathleen. And I know that there's a whole team of folks that work on operational approvals, and that some are present here. So that's lovely that we can get more voices if we need for any questions that might arise. I think the first question that I have offhand that always comes to mind is what's the most common issue or question that arises when research teams are moving through the IH operational approval process?
I would say that it's a lack of understanding of what the process is, because often when we email them the introductory email saying, hey, we got notice that you have an REB application and OA is also required, they say, well, I've already done this. And they don't understand that it's a completely separate process. The operational approval team does not have access to your REB application, which is why you will notice some overlap between the questions on the operational approval form and within your REB application. And also the perception that we are just there to put up roadblocks. And that's simply not true. We want you to do research with us. We will help you facilitate doing research with us. But all of these things takes some time. It's not that great of a burden if you've already created your protocol and web application. As I said, you can copy and paste a lot of the information from one into the OA form. And then just like to be kind, the OA team is a small but mighty team, and we are just facilitators. We actually have no approval granting privileges at all. So I think that would be my take home.
Thanks.
Yeah.
We have a ask from Elijah asking if the slides are available somewhere.
Yes, the plan is to put them up on our public website within the Interior Health Research webpage.
Great question, Elijah. And I can say too that we're recording these sessions, and fingers are crossed, tech willing, we'll be able to post these after too. I'm always tech willing, always hoping. Great. Oh my gosh, what was my next one? Oh, so you had mentioned there's that Interior Health doesn't have access to the RISE platform. And I wondered, and I know that other health authorities do have access. And so I wondered if there's anything else that you can think of offhand where Interior Health is a little different than other health authorities in the operational approval process.
Yeah. In Vancouver, I think it's either Fraser or Vancouver Island, they actually make the study team go out and find the approvers themselves instead of it being on an operational approval team to determine who the most appropriate administrator would be. And so like it is at the end of the day the responsibility of the study team to get the approval, but we take a much more active role in trying to receive that approval for the study team than other health authorities.
Thank you. And I'm just going to keep asking questions unless more pop up at my lap. I'm hoping I'm not missing any because I'm just going to keep firing. I do know that we have a couple of minutes, and so I'm happy to ask those questions because I feel like many people might have them, but maybe they're not sure on how to space them. So I wondered if I'm a student and I'm doing a research project, and I'm a little unsure as to what what this looks like, what steps to take, where I should go. What would you say to me as a student for first steps into doing research with IH? What advice would you give to me?
First steps, I'd say, would be to check out this link right here because we have some great infographics on, is your study research, or is it a quality improvement study, or is it evaluation? I would also recommend checking in with your supervisor and asking them, if you haven't done the REB application yourself, asking them, do you know if your application has been harmonized with IH? Because I heard that needs to happen if we're going to use IH resources. And then never hesitate to use this email to ask general questions about research, because that's what the operational team is there for, to not only review operational approval applications, but to also answer general research questions and redirect to the appropriate people as necessary from those emails.
That's awesome. Thank you. And I'll ask one more question, and then I feel like I'm interrogating, so I'll do one more question, and then we'll move on to our next speaker. This has been fabulous and so much information, and I loved how the slides were laid out. I thought it was really comprehensive and well done. I just wondered, oh my gosh, I had one, hang on, it's coming back. Oh yes, you had mentioned before about how Interior Health has champions. And I wondered if you could expand a little bit on what champions in Interior Health look like. You don't necessarily have to add the portfolio, but what that looks like, what championship within Interior Health looks like.
Sure. So for what I mean by champions is we have, say, specific departments that get requests often for services, and there is one specific person in that department that we are able to reach out to and say, hey, there's an application that's within your portfolio. They receive that email that we send them, as well as the red cap invitation to review the application. And then what they do is they review the application and they send it out to the most appropriate person within their team who would be giving approval for the request or the ask from IH.
Great. Thank you so much. Is there anything else for the last takeaway to share with everyone watching before we move on?
I know I kind of zoomed through it, but I thought there would be more questions. I wanted to leave lots of time for questions, so I'm sorry for that.
Yeah.
But yeah, check out the two websites listed there. And again, if you have any questions, don't hesitate to reach out to research@interiorhealth.ca.
That's perfect. Thank you. And I always say, if there's no questions, I just answered it really well. That's how I think of it. If I've left everyone speechless because I've done such a darn good job, and I really thought that you did. So thank you so much to Kathleen, and bravo for the great presentation. Much appreciated.
Thanks, Kim.
All right. So up next, Kathleen, when you get a sec, please stop sharing your screen.
Yes.
Thank you. Perfect. Okay, and my computer didn't mute me. I can see, so that's great. It tends to do that every time we do a segue. So up next is, also I'm very excited to introduce this speaker. So she's with Interior Health. She's a librarian. Her name is Rebecca Johns. And Rebecca will be presenting on the Interior Health Publications Hub, known as IH PubHub. And please note, IH Library Access is only available for IH staff, but this information might still be relevant to you, depending on where you are and where you're located. And Rebecca, I'm happy to share you as well, spotlight you as well. Hang on. Replace spotlight. There you go. Okay, take it away, Rebecca.
Okay, thank you, Kim. Yes, my name is Rebecca Johns, and I am a librarian with Interior Health Library Services. The IH PubHub, or the Interior Health Publications Hub, is a new platform for discovering, sharing, and celebrating publications authored by Interior Health staff and physicians. It's something that we at Library Services have been developing over the course of about a year. It just launched in September, and I'm really excited to be able to share it with you today. I would like to acknowledge the traditional, ancestral, and unceded territories of the First Nations on whose land we reside as guests. I'm presenting today from the beautiful territory of the Syilx peoples and what's now known as Penticton. So in this presentation, I'll briefly cover some background information about how and why we developed the PubHub and what's included in it. Then we'll take a look at how it can be used to find publications and how Interior Health affiliated authors can submit their publications. So first, just a bit of background about Library Services and what we do more broadly before we get into this particular project. So the mission of IH Library Services is to connect all Interior Health staff throughout the region to information services that support their work. We do this through access to information via our books, our databases, and other digital resources such as curated subject and information guides. We provide expert searching for staff and physicians looking for information to support patient care, administration, education, policy changes, or research. So keep that in mind the next time you're working on a literature review. We provide current awareness alerts, and we have customized and regular training and using library resources. We're a busy group. We have physical libraries in Kelowna, Kamloops, Vernon, Penticton, and Trail, but we work virtually across the region. We run our own website, and that includes both informational pages, such as those guides that I mentioned, and links to our subscription databases, as well as the catalog, where users can search our print and ebook collections. So having that digital infrastructure is important because having that already in place and having staff with the technical expertise to build upon that is what allowed us to take on this new and exciting project of collecting, organizing, making findable and shareable all of the publications authored by staff and physicians with an Interior Health affiliation. So we're a staff of 8 with 4 librarians, 3 library technicians, and 1 library manager. The PubHub was a team effort. That team included myself, Connie, our manager, and Erin, Paula, and Jane Marie, our wonderful library technicians. So I want to say a big thank you to all of them. So moving on to the PubHub itself, what exactly is it? So very simply, the PubHub is a searchable repository of publications authored by IH staff and physicians from 2001 to present. So in this database, there are linked fields such as the author's name and subject headings. So you can do both targeted searching or browse and explore and see who's researching and publishing on various topics, allowing us as individuals and on an institutional level to find, share, and celebrate the research outputs of our community. So a bit of background about the PubHub. So we're not the only institution to have done something like this. Those of you who have a university affiliation may know that most universities these days have very large institutional repositories run by their libraries. These are quite big, and they also serve an archival purpose and facilitate compliance with open access policies. And they also have full-time staff who work solely on repository management. That's not what this is. But there are other health authority libraries who have done something like this on a smaller scale. Fraser Health is one. And I think how this began was that after hearing about Fraser Health's repository, Holly Bruler and Kim, I think you were part of that too, approached us wondering if we had the capacity to do something similar. And as it happened, it was something that the library services manager, Connie Boulding, and I had talked vaguely about before, thinking that it would be cool to find some way to feature IH authors and their publications somewhere, somehow on the library website. So with that nudge from the research department, we decided to go for it. But why? Other than that, it's kind of fun to showcase what colleagues are up to. Why take this on? It was a lot of work, probably more than we realized when we first began. So what's the value? What does having a specialized, fully searchable collection of publications do for an institution? So there are three main benefits. First is that when you collect and index all of these publications, the database itself becomes a source of information about IH publishing activity. So this is a chart that's taken from a search that we ran in PubMed, which is the US National Library of Medicine's database of biomedical literature. So we searched for author affiliations of Interior Health Authority or the various hospitals within IH. And you can see that publications have been increasing. And maybe there's a vague sense among those of you conducting research that more and more is being produced. But by collecting and indexing all of these publications over time in the PubHub, this allows us to capture and quantify those outputs. And then because of the way that we catalog everything, we can also gain information about who is publishing and the different topics that are being researched and written up. Second, it's a platform for celebrating achievements. And to this end, we've added features like an article of the month and an RSS feed of recent editions, which I'll show you when we get into it a little bit later on. And then finally, the PubHub facilitates discovery and access. It's a direct and simplified way for people to find and read your publications, and a way for you to find and read your colleagues' publications. The database itself is freely available to anyone, anywhere. So Kim had mentioned that library services is only, IH library services is only for IH library staff. And that's true, but the website is publicly available and the database is publicly available as well. We don't archive full text manuscripts directly in the database, but we do link out to the journal's websites. So in cases where the publication is an open access publication, meaning that the journal doesn't charge a subscription fee, those articles can be read by anyone, anywhere. When it's not open access, that's when our services come in. And so if you are IH staff or a physician, you can send us an email and we can source that full text for you and send it to you. But users without an IH affiliation would need to contact their own institution's library services to see if they could provide a similar service. And that just has to do with our licensing and sharing agreements among libraries. Okay, so inclusion criteria, that's librarian speak for how we decide what goes into a collection, whether it's books that we're adding to a library or the publications that we're adding to the PubHub. So to be included in the PubHub, a work must meet three criteria. First, it must be published. So this includes articles, books, book chapters, or conference abstracts. PubHub doesn't contain anything that's self-published or gray literature or any internal interior health documentation or policies or things like that. It's strictly published material. Second, the work must pertain to the work and mission of Interior Health. So although we're aware that there are definitely some folks within IH who have awesome side projects, writing novels, and that's like so great, but it's beyond the scope of what's included in the PubHub. Finally, at least one author needs to be or have been an IH employee or physician at the time of publication. There will be some cases we think where works without an IH affiliated author would be included when the research was conducted at an IH site or made use of IH data or otherwise has a really strong connection to Interior Health, and we'll be working with the research department to identify any publications that would fall under that category. So the stages of developing the PubHub began with the initial design of both the database and the website. So we took what we already had in place for our books and media catalog and the library services main website, and then we made modifications to create a parallel site and catalog. This is actually a very long process, and if I were presenting to other librarians, I would go into much more detail about some of the specific adjustments that we made to our cataloging templates. But I do just briefly want to mention that quite a lot of thought and testing and revision went into this stage of development. It was important to us to get the infrastructure in place in a way that would sustain growth of the database and continued use over time. The next step was finding the publications. So as I mentioned, the PubHub goes back to 2001, which was the formation of Interior Health Authority. And to find publications going back that far, we used that PubMed database, the National Library of Medicine database, looking for any author affiliation of Interior Health using an IH email as a author correspondence email, and then all of the hospitals within Interior Health. The library technicians then created records for over 600 articles that came back from that search. The search is saved and it's set to run monthly as an email alert. So anytime over the course of each month, if any new publications come out that match that search criteria, those will be emailed to us and then they'll be cataloged. So we know that this search is incomplete and it's not catching everything. I've looked at some records where one IH author is listed, but then I recognize another name. So I've been able to add that other person in that way, but I don't know everybody. So we're really hoping that authors will go in and check and make sure that their work is there and alert us if it isn't. Okay, so now that you know a little bit more about the PubHub, let's jump in and take a look at it. Okay, so this is the Library Services main website, and up in the top banner, we have a link to the PubHub.
Oh, sorry, Rebecca, it's not sharing.
It's not sharing that. Okay, thank you. Are you seeing it now?
We're still seeing the search the IH PubHub.
Is it the live version though? Like okay, let's go here. Do you see the library website? October is Medical Library Month?
No.
No, okay. What about, now we do. Okay, great, excellent.
Please go ahead.
Okay, so this is the library's website. And we have a link to the PubHub up in our banner menu. And this is the Search the PubHub page. So you can see that it kind of mimics the library website with the banner and the search bar. So we can, of course, enter a phrase or a keyword as a search, but I'm actually going to begin with an empty search. So this, by not entering anything at all and just clicking search, this is going to pull up everything that we have in the PubHub. So if you were looking for a particular item or if you were looking for information on a particular topic, this would not be the way to search. But if you're looking for information about IH publishing activity, kind of an overview of everything that's been published, what's going on, this is a really nice way to do that. So we're going to start with that. I'm just going to click the search button. And this brings us into the PubHub database. So you can see that at this time, there's 628 items in there. The vast majority of them are articles. So by clicking on any of these tabs with the number of items there, that will filter to just the articles or just the conference abstracts. And you can see we only have a couple of book chapters and one book at this time. And that's because our initial cataloging was based on that PubMed search, and PubMed is an article database. So we're very likely missing book chapters and books. And so this is an area where we would be relying on authors to let us know both retrospectively and moving forward when they have a book chapter or a book coming out, because a book's a big deal. It's pretty exciting and we want to get that in there, but it's a little bit more difficult for us to know that that's coming out and that that's happening unless we happen to know the person who's the author. So just going back to the main tab with everything, the default publication is by default sort is by publication date. We can change that, so you could sort alphabetically by title or by the IH author's name or by the date added. So if I change it to date added, we see what's been added most recently. And most dates here are going to be 2024 from that last monthly update that we did. But we have one that's 2013. That's because Sherry found out about the PubHub and searched for her article and it wasn't there, and she let us know and we put it in, and that's awesome. So thank you, Sherry. We want to see more of that. And so that way, you can either look at it based on what's been recently published or look at it based on what's been recently added. So if I do click on a title, that will open up the full record for that item. We get the full citation that lists all of the authors, not just the IH authors. But then we've pulled out those IH authors and their names are listed here. And we have this set up as a standardized, systematized way of looking at names. So it doesn't matter whether Christopher Bilisky publishes under Chris or Christopher, or if it's listed as Ian Marie or just Ian. These are the way that their names will appear in this database. And then when you click on a name, it actually links to everything that person has been listed as an IH author on in the PubHub. So we can see all 7 publications listed there. Going back into the record and scrolling down a little bit, we include the abstract where that's available. We have subject headings, and these are another set of standardized terms that are assigned to each item in the PubHub, kind of trying to describe what the main subjects of the work are. And these are also standardized terms. And again, they're linked. So if we click on one, it will pull up everything else that we have where that is the main subject of the work. And then finally, within this record, we have the journal website and link. So this is where you click on that. It will take you out to the publication website. In this case, this is an open access article, and I know that by this open lock symbol. You can always look for that, meaning that there's no subscription fees associated with this journal or this article. So anybody anywhere can read this one. And then again, if that wasn't the case and you were being asked to pay for it, if you're with IH, send us an email. Our email is here in the record. Send us the citation and we should be able to get that article for you. If you're not with IH, contact your own library and hopefully they'll be able to do the same. So if we go back to that main list of results, I'm going to get rid of that subject heading for a minute. So we're looking at everything again. We have some additional filters over on the left side. So we have those subject headings. These are the same terms that would appear in the record. And they give you a count of how many articles that we have where that's one of the subjects that's listed on the item record. And so you can also click there and apply filters and pull up everything on what did I choose? Long-term care. And so that's another way that you can browse through subjects. Not all of them are listed there. I think it's the top 20, but it's kind of a nice way to see what some of the more popular topics that have been published on are. Also scrolling down, we have IH authors listed. Again, it's, I think, about the top 20 with the number of articles, and you can click on a name and see everything by that author. The publication date filter, you can change to a range or a single year. So if we just changed it to 2024 to 2024, we'd see everything that has come out within this year. So that's a way to kind of browse and take a look at things without really having an intention of trying to find a particular item or a particular topic, and just get a sense of what's out there. Of course, we can also do a keyword search, and that will pull up everything where that word appears in the record. We also have the option of an advanced search, where you can enter a complete title or some keywords in the title. You can search the subject terms by beginning to type the word, and it will pop up what those search terms are, and you can add them in that way. Similarly with the authors, you can find an author that way and then run the search. Which I'm not going to go through right now. It's pretty self-explanatory, I think, but if you ever are in there and having trouble figuring out how it works or would like a little bit of instruction, please reach out. We're always happy to share more about how to use this. Going back to the main page and scrolling down a little bit, this is where you'll find some of those more celebratory features that we've included. So we have the article of the month. This is just something that the library staff picks out, something recently published. Maybe it's something that we've gotten some literature search requests for, so we know it's something that people are interested in, or maybe it has quite a few IH authors listed on it, and that will change pretty much every month as new things come in. And then we have recent additions. This is an RSS feed, so anytime we add something new to the database, this will be updated. And if you click on the title, it will bring you into the record there. In the middle, we have a link out to the research department. So if folks are exploring this and interested in doing some research, they can head over to the research department to get started. A little bit more about library services and what we do. We also have a link to our research, health research, and writing and publishing information guides. So these are some guides that we've put together with books in our collection, as well as external web resources on the writing and research process. So I encourage folks to check those out as well. And then finally, our informational page. This covers a lot of what I've already talked about here today, but just scrolling down a little bit, one final thing is our submission form. So if you are an IH author and you've checked the PubHub and your work isn't in there, you can use this form to let us know about that. And also moving forward, if you have something new coming out, it's another great way to make sure that we include that in there. So we just ask for a few things like the citation, making sure that we've identified anyone within IH who is an author on that paper. We're trying to add some additional subject headings for strategic priorities. So we'll be able to have those as those linked fields, so we can click on any one of them and pull up everything that's been written and published that aligns with that strategic priority. And some keywords to help us identify the best terms to use for your subject headings. So yeah, we really do encourage those of you who have been involved in research and publishing to check check for your work. Let us know if we've missed something. Like I said, I know it's not complete at this point, but the more eyes that we have on it, finding things that we've missed or identifying authors that weren't identified in the first round, those books and book chapters, the better that this will be. It's only been out for about a month and a half, so I don't really have any data on usage or anything like that. But it's Medical Library Month, and we're running a little scavenger hunt as a promotional thing for library services. And one of the questions that we ask at the very end of the scavenger hunt is if folks have learned anything new. And I've been so pleased to see so many people responding that they didn't know about the PubHub, which makes sense because it is so new. But not only that they didn't know about it, but so many comments saying, this is so cool, and this is my new favorite thing, and how exciting to see what's going on within IH. So that's really, just as a little start, been really gratifying to see. And yeah, really nice initial feedback to have gotten. So that wraps it up for me, and I'm happy to take any questions.
You're muted.
I got it. Thanks so much. Thanks so much, Rebecca. That was on me. I can't blame my computer that time. That was me. I want to say huge gratitude as well for your entire team for making this happen. I remember the initial conversations that were had, and I just, like, I was literally blown away when I was shown this. It surpassed everything that I think we thought it could be. And I do welcome folks to write questions into the chat, and I'm happy to relay them over. And in the meantime, I wonder, I note that there's differences in PubHubs that sit within different health authorities and different academic institutions. And I wonder what makes the IH PubHub IH PubHub.
Well, beyond the obvious that it is built entirely around the work that IH staff and physicians have done in being a collection of IH publications. I think I think the fact that I don't really know how some of the other health authorities have built theirs, but one thing I really loved about the way that we put this together was the team effort that went into it and the level of attention. I think one of the library technicians at one point said something like, you get a bunch of detail-oriented people together and every single decision is multiple emails back and forth, and like, oh, we have to actually get on Teams and talk about this. Like, we looked at, the order of fields and just, the level of detail and consideration, and really trying to think about how people would use it and how it could be sustainable. Really, in the process of creating it, really stood out to me as something. I don't want to say that it's unique because I don't know what went on at some of the other places, but that stood out to me as a defining feature of how it was created.
For sure. And I have to say, I'm delighted to hear that you're already getting additions in, that people are already submitting their work in. I think that's really
yeah, that's been really exciting to see. Almost within the first couple of days of launching, we were getting submissions, so that was really great.
So amazing. And my understanding is this is published materials. So is it only connected to research, or does it also connect to QI and evaluation work?
Yeah, so anything that's been published. So if a QI project has been published in a journal, then we would include it. We aren't kind of filtering by anything further than just, was it published?
Right. Lovely, lovely. Yeah. And that's so great because quality improvement, evaluation, and research, I call them siblings. Like, they're so connected, and that's the way that my brain relates them, is that we're all very, very interconnected in different ways, and have a lot of a lot of the same purpose, which is to support effective change. You're getting a lot of congratulations in the chat.
Oh, that's nice. Thanks.
And it's a fantastic resource. And I'm so grateful that, you know, I got to be a small part of it, and that, and to see it come to fruition is just, it's honestly, it's mind blowing.
Yeah.
Yeah.
Yeah, I will say, you know, we had a couple of meetings where we presented to some folks from research as it was ongoing to get a little bit of feedback about how things might be used from more of a user perspective. So that was, you know, that was really good too, that we weren't doing it in isolation, and we were really looking at what different ways that it could be used and what people would want to see and be able to search on, and that sort of usability factor.
And so, what's next for showcasing and sharing this throughout Interior Health? I know that there was planned steps to be able to share, and I know Library Month is one of the steps to be able to share. And I know we are going to be sharing in our Evidence Matters updates, our monthly updates, which is a monthly newsletter that we send out. And we're also going to be sharing, that's how we're going to be sharing, is the article of the month will be showcased there, as well as a little blurb about the IH Hub PubHub. But is there any other plans in the works to be able to share this great work?
Yeah, it's a good question. Yeah, we had kind of our initial launch. It's been kind of incorporated into that Medical Library Month scavenger hunt. Doing this here today. We're happy to do any other kind of training or lunch and learn if there's different teams within IH who would like to learn more. We can come and speak about it. Yeah, we've done, I think we've put it in some other newsletters. We have two of our librarians are kind of our marketing people, and they're kind of working on some plans for more promotion as we go moving forward. Well, happy to take any ideas too.
For sure. Well, we welcome to support. So whatever that looks like, let us know, and we're happy to help continue to spread the word in any way that we can. And you get more congratulations too. And I feel like that's perfect. So we're 1 minute away from close. Is there anything else you wanted to share or say before we end your presentation today?
No, thank you for having me here today.
Oh, it's been our pleasure. We sincerely appreciate you carving out the time to share this great work with us. And I'm hopeful. I would love if you would come back again next year and share an update as to where it's at, and so we can all see the growth, because I feel like it's going to be exponential in the next year.
Yeah, totally.
So, well, thank you so much, Rebecca.
Okay, thank you, Kim.
Okay, and on that note, we are exactly at time, so 2:45. We've reached the end of our day together, and we're going to close off the Zoom session shortly. We hope to see you again tomorrow at 12 p.m. for presentations connected to community-based wellness across the age continuum. And there's still some space left to register if you haven't already done so. You can find all the registration links on the IH Research Department events webpage. So when you close off, there's going to be a survey link that'll pop up. And we are also going to add this into the chat box. And we want to thank you in advance for taking the time to be able to submit your thoughts with us into this evaluation survey, because it'll support us and help shape all the research weeks in the years to come. So on that note, thank you to all the presenters, to the attendees, to the fabulous and amazing Elder Bonnie for sharing her time and her voice with us today. And we wish you all the best. Take good care of you and yours. And thank you for being part of the first day of IH Research Week 2024. Talk soon.